Viewers, good day to all of you. This is Dr. BK for you, and today I am going to discuss about the popliteal fossa. So, the popliteal fossa is not only an important structure, but it is also somewhat comparatively very easy to remember. Now, why actually this popliteal fossa is important? First thing is, the major vessels and nerves to your leg or the crural region is actually going to descend through this popliteal fossa. So, mainly the femoral vessels are going to continue as popliteal vessels, and your sciatic nerve, which has divided into the tibial nerve and the common peroneal nerve, is also seen in the popliteal fossa. So, the major neurovascular bundle to the structures below the knee is going to actually pass through the popliteal fossa. Okay? So, that is why popliteal fossa is actually an important structure where the neurovascular aspects are actually present. So, with respect to the popliteal fossa, today we are going to discuss about mainly the situation where actually it is present, then followed by the boundaries of the popliteal fossa. So, what are the limitations or extent of the popliteal fossa, followed by the contents of the popliteal fossa. So, we are going to list out the contents. What are all the contents which are present in the popliteal fossa, and followed by that we are actually going to describe in short about each and every content. Then applied anatomy. So, any applied aspects, surgical aspects or any clinical aspects with respect to the popliteal fossa we are actually going to discuss. Now, if you look at the popliteal fossa, where actually it is situated. So, we all know, or we can tell, it is actually situated behind the knee. It is a pit or a depression, and roughly when looking at the muscles which are present or which forms the boundaries or extent of the popliteal fossa, then that space in between the muscles, of course it is an intermuscular space. That intermuscular space is roughly diamond shaped. Okay, so you can simply tell it is actually a diamond shaped fossa which is present, and since it is present behind the knee, it is called as knee pit. So, that is why the knee pit is actually called as the poplet. Poplet is nothing but the other name for knee pit. Now, here you can compare this popliteal fossa to the cubital fossa of the elbow. So, in the same way, here also what happens is synonymous to the cubital fossa, here you have the popliteal fossa. So, it is a diamond shaped hollow space. As I have already told you, it is rather a intermuscular space. We can tell it is actually an intermuscular space formed due to the divergence of the hamstring muscles, which you have already seen in your previous classes. That is the biceps femoris, semitendinosus and semimembranosus. As they reach the tibia, what happens is they diverge to the lateral and medial condyles to get inserted. So, it is not only the divergence of the hamstrings near their insertion, but also divergence of two muscles, posterior compartment of the leg muscles, the gastrocnemius muscle, its divergent origin. So, it is the divergent insertion of hamstrings and divergent origin of gastrocnemius, which leaves a space around these muscles, and it is actually called as the popliteal fossa. Okay. Now, this depression or hollowness you can appreciate in a flexed knee. So, when you just bend your knee, then you can see the depression. Now, why not? When it is actually extended or when you are standing upright, it is a bit difficult to appreciate this depression while you are standing or in an extended knee, that is because of the tough fascia, the deep fascia which is present. Okay. So mainly the deep fascia is very tough and unyielding. So that is why what happens is when you slightly flex the knee, the deep fascia as well as the tone of the muscles are relaxed a bit, then you can actually appreciate the hollowness. Okay. So that is something about the introduction regarding the popliteal fossa. So when they ask about the popliteal fossa, in the introduction you have to write it is actually a diamond shaped depression which is present, where it is present, in behind the knee. Okay. So it is a depression which is present behind the knee, and it is due to the divergence of the hamstrings insertion and divergent origin of the gastrocnemius muscle. So like any other fossa, or for that matter any other region we have seen in case of your femoral triangle or your adductor canal or cubital fossa, in the same way here also the boundaries are as usual. It has got a roof, it has got a floor, and it has got 4 walls: supromedial, superolateral, infromedial and infralateral. Okay. So that will be your 4 walls which you are able to see here: supromedial and superolateral. This is superomedial and this is superolateral. Then what you see here is the infralateral and this is the infromedial, and that is the divergent insertion and that is the divergent origin of these muscles, and that is the fossa. So as I told you, on the above what you have is the roof and below what you have is the floor. Okay. But again I would like to emphasize one thing is roof and floor all only in the prone position you will be able to call it as roof or floor, but in the anatomical position the roof is actually your posterior most limit or the posterior wall it can be called, and the floor can be called as the anterior wall. So correctly speaking it should be the roof should be your posterior wall and your floor should be the anterior wall, but because for the sake of understanding and not only that, if you are going to do any surgical procedure or clinical procedure in that region, especially in the popliteal fossa, naturally the patient is going to not stand upright, instead is going to lie down, and especially it is going to be in a prone position. So assuming that in that position, that is why the boundaries of popliteal fossa has been labeled as the roof and floor, apart from the 4 the lateral boundaries: superomedial, superolateral, infromedial and the infralateral boundaries. So we will see the nature and what are the structures forming the each and every wall of the popliteal fossa. So superomedially, you know, semimembranosus and the semitendinosus, they form the supromedial limit of the popliteal fossa. Superolateral limit is mainly formed by the biceps femoris, the tendon of biceps femoris, which is going to get inserted into the upper end of the fibula. Infromedial, it is by the medial head of gastrocnemius, and infralateral, it is going to be the lateral head of gastrocnemius, and deep to the lateral head of gastrocnemius you also have the origin of the plantaris muscle. Okay. So infromedial and infralateral is by the 2 heads of gastrocnemius. These 2 heads of gastrocnemius, they will unite to form a single muscle belly, and they are going to join with the soleus muscle and they are going to form the tendocalcaneus. Okay. So 2 heads of the gastrocnemius forms the infromedial and infralateral. Apart from that, along with the lateral head you also have a slender muscle which is the plantaris muscle, which is also forming the infralateral part or the wall of the popliteal fossa. So the 4 walls you are able to identify here. So this is supromedial. So especially how can you tell immediately to identify the superomedial boundaries? You see two muscles, semimembranosus and semitendinosus together. So that is how you identify it. Biceps femoris will be lateral to it. Laterally it is biceps femoris. Now you might get a general doubt. Suppose if there is only this part is exposed, where how to find out which is medial or which is lateral? That is why I told you the tendon of biceps femoris and the common peroneal nerve are together. So very intimately related, the common peroneal nerve. So when you identify this nerve, then naturally the muscle should be your biceps femoris. So when you are able to identify the biceps femoris, then it is very easy to identify the other three boundaries. The other way is to looking for this tendon, semitendinosus and semimembranosus. They will always be together. One is half membranous and other one is half tendinous. So these are the four boundaries. Two heads of gastrocnemius, biceps femoris, semitendinosus and semimembranosus forms the four walls of the popliteal fossa, roof. So coming to the roof, mainly it consists of skin. Deep to the skin, what you have is the superficial fascia. Okay, so superficial fascia mainly consists of fat in the superficial fascia. Then you have cutaneous vessels and nerves. Now here in the superficial fascia, you can come across the small saphenous vein. Okay, so the small saphenous vein you can see, and not only that, one more structure piercing the deep fascia and coming superficially is the posterior cutaneous nerve of the thigh, or the posterior femoral cutaneous nerve. Then deep to the superficial fascia, what you see is the deep fascia, which is actually called as the popliteal fascia. So the popliteal fascia is a transition of deep fascia from the above that, it is called as the fascia lata of thigh. It is actually called as the fascia lata of thigh, and below it is actually called as the fascia crurai, which is the fascia of the leg. So between the fascia lata of the thigh and the fascia crurai, so a transitional fascia is nothing but popliteal fascia, which is also a very thick fascia. So again, your small saphenous vein will pierce this deep fascia to go and terminate into the popliteal vein. Same way, your posterior femoral cutaneous nerve has to pierce this deep fascia and then come to lie on the superficial fascia to supply the skin. Okay, so these two are the things, small saphenous vein and the posterior femoral cutaneous nerve or posterior cutaneous nerve of the thigh. So that forms the roof. You have the skin, superficial fascia. The deep fascia is actually the popliteal fascia, and two structures which are piercing the deep fascia is the small saphenous vein and the posterior femoral cutaneous nerve. So now coming to the floor of the popliteal fossa. So mainly you see the popliteal surface of femur, the lower 1/3 posterior aspect of the femur is actually called as the popliteal surface. Same way in the anterior, what you see the lower part is the patellar surface. Both are PP, stands for, one stands for the popliteal surface at the back side of the femur, and one stands for the patellar surface on the front side. So popliteal surface of femur, knee joint, you can see capsule of knee joint, and one more ligament of the knee joint, oblique popliteal ligament you can come across, and fascia covering a muscle, that is the popliteal muscle. Okay, so fascia covering the popliteus muscle you come across, and then you also come across the upper surface of tibia, posterior surface of tibia above the soleal line. Okay, so you are able to see the popliteal surface of the femur, the two femoral condyles, and then what you are able to see here is the knee joint, your capsule of the knee joint, that is the oblique popliteal ligament. Then you have the popliteus muscle, the fascia covering, then upper part of the tibia up to the a line will be here, which is actually called as the soleal line. Okay, so when you look at this diagram, this is actually a very simple line diagram which is drawn here. So I would like to advise you to actually see this diagram as many times as possible and practice this diagram. So it will be easy for you to reproduce, because many of the students in anatomy, what happens is they don't give much importance to the diagrams. They think that only writing answers will fetch them marks. But with respect to anatomy, diagrams play a very important role. You have to draw a diagram. If it is a short note, at least one diagram is expected from your answer. If it is an essay question, minimum 2, and definitely you can also make 3 diagrams. So to draw diagrams very fluently with flow and speed in the exam, definitely you should practice. And that too, your diagrams, as I told you, it need not be a very artistic or beautiful diagrams. Only thing, it should, even it's a line diagram, it is okay, but the diagram should be correct. You cannot draw some scribble, some lines, or very shabby, dirty diagrams. It should express what are you all trying to say in your exams. So that is why I am telling. So what happens is, we try to mainly, apart from projecting pictures, for you to understand some of these diagrams, we try to actually incorporate in these lectures so that it saves your time. Otherwise you have to go on hunting from books to books and find out. But what happens is, in our PowerPoint lectures, what we do is, we consolidate all the points after referring many textbooks. So the clinical aspects, the surgical aspects, and the important key points what you are supposed to actually write in your examination when a question is asked, and the necessary diagrams we supported through this. So that is why what happens is, these lectures comes in handy for you. But only thing is, you have to utilize these lectures by looking it again and again, only repetition. So mainly what happens is, repetition is very, very important in case of anatomy, because anatomy is a very volatile subject. You tend to read it very fast and you tend to forget it even more faster. Okay, so it just escapes off from your brain very fast. So today you read, and tomorrow morning you get up, you remember only 50% of it, and tomorrow evening you remember only 25% of it, and day after tomorrow you remember only 10% of it. So only thing is, you have to keep on repeatedly read it. If time permits, I will actually what happens is, specifically or exclusively on one session, I will just try to incorporate some tips of how to actually read anatomy and remember anatomy. Very soon I will try to make a lecture on that. So for time being, we will come back to our popliteal fossa class. So in this, the floor structures are mainly the tibial condyles, femoral condyles. Then you are able to see the capsule of the knee joint, oblique popliteal ligament, then popliteus muscle and the fascia covering it, and the tibia up to the soleal line. So what are the contents? So as you can see, the popliteal vessels, that is the popliteal artery and vein. Then what you see here is the tibial nerve and the common peroneal nerve. Okay, so you have the tibial nerve and then you have the common peroneal nerve. Then you have the genicular branch of obturator nerve, termination of small saphenous vein, popliteal lymph nodes and fat. Okay, you have the popliteal lymph nodes, and then you have a fat. Then of course the posterior femoral cutaneous nerve. So these major contents you can see: popliteal vessels, tibial nerve, common peroneal nerve. This is very very important. And did you notice that fat is also a genuine content? In most of the fossas you come across, you see fat, because fat is a loose packing material. Since it is a hollow space or fossa, naturally apart from the structures occupying the main part of the fossa, all the remaining spaces has to be filled with fat. So only then what happens is it prevents any mechanical injury during movements to the major structures in the fossa. So now we have listed out the contents. So popliteal vein and artery, tibial nerve and common peroneal nerve, termination of small saphenous vein, posterior femoral cutaneous nerve, genicular branch of obturator nerve, popliteal lymph nodes, and then what we saw at the last is the fat. Okay. So now we are going to see the contents one by one, but before that, how the structures are arranged. Mainly three main structures you come across. One is the popliteal artery, the second one is the popliteal vein, and the next one is the division of the tibial nerve and the common peroneal nerve. The popliteal artery is the one which is present at a more deeper structure, or it is present more anteriorly. Then the intermediate structure is the popliteal vein, and then followed by it more posteriorly or nearer to the roof, you can tell it is the tibial and the common peroneal nerve. Okay. So that is how from deeper to superficial, or from anterior to posterior. Now first we will look up this popliteal artery. So it is a continuation of the femoral artery. It is the extent of the popliteal artery is from the osteoaponeurotic opening of the adductor magnus, hiatus of adductor magnus. Okay, you have opening here, no, adductor magnus muscle. Between the femur bone and near the adductor tubercle, what happens is there is an opening, osteoaponeurotic opening, through which the femoral artery continues as the popliteal artery and up to the lower border of popliteus muscle, where actually the artery will be dividing into anterior and posterior tibial arteries. Anterior and posterior tibial arteries. Now, if at all, sometimes what happens is, if it is going to divide at a higher level, rather than the lower border of the popliteus, if it is going to have higher division somewhere in the middle, then the anterior tibial artery will pierce the popliteus muscle and it enters the anterior compartment of the leg. Or sometimes the artery, instead of bifurcating, that is dividing into two, it might trifurcate into anterior tibial, posterior tibial and peroneal artery. So it is actually trifurcating into three branches. Actually peroneal artery is from the posterior tibial artery, but sometimes it might have a direct origin from the popliteal artery. Okay. So all these things you should keep in mind with respect to the popliteal artery, because in case of popliteal aneurysms, if you are going to treat, or any other pathology with respect to the popliteal fossa, then this variation you should take into account before carrying out any procedures. Okay. So that is the extent up to the lower border of popliteus, you have anterior and posterior tibial arteries. So as I told you, more deeper structures, it is present near to the floor. Now if you look at the relations of the popliteal artery from above downwards, the deep relations is going to be your floor structures. mainly your popliteal surface of femur, your oblique popliteal ligament and fascia covering the popliteus muscle. Then superficially in the proximal part, it is overlapped by the semimembranosus muscle, and the distal part by both heads of gastrocnemius, semimembranosus and both heads of gastrocnemius. Then in the middle, it is crossed by the popliteal vein and as well as the tibial nerve. So here if you look, the popliteal artery takes a oblique course, somewhat it runs obliquely. So laterally it will be related to the biceps femoris, then tibial nerve in the upper part and popliteal vein in the upper part, but these two crosses medially. So it is related to the lower part medially. Okay, so the tibial nerve has got a vertical course, the popliteal vein has got a slightly oblique course, and it is intervening between the artery and the tibial nerve. So the artery actually crosses posteriorly, the vein crosses posteriorly, the popliteal vein, and the tibial nerve crosses completely from the lateral side to the medial side. Okay, so the medial relations will be semimembranosus in the upper part, and in the lower part you will have the popliteal vein and the tibial nerve. Laterally you have the biceps femoris and popliteal vein and tibial nerve in the upper part. In the lower lateral part we have the lateral head of gastrocnemius. So almost you can see the boundaries of the popliteal fossa are only making relations with the popliteal artery. Supralaterally or supramedially, infralaterally, inframedial boundaries, they only are again related. Only thing you have to remember is the tibial nerve crosses the artery from lateral to medial side posteriorly along with the popliteal vein. Okay, so crossed by the popliteal vein and tibial nerve from lateral to medial side. Now coming to the branches, so it gives three types or three sets of branches. You can tell cutaneous branches, which is actually going to supply the skin of the back of leg. Again it is only blood supply, not the nerve supply, because nerve supply is very important, where you know, so that where there is a cutaneous loss sensation, when there is a loss of sensation, then you can identify which nerve is involved. But here it is blood supply, not as important as the nerve supply. It has cutaneous branches, muscular branches, again blood supply to the muscles, the adjacent muscles, and then articular branches. So of the three, the third one, which I told you, the articular branches are very, very important because it forms an anastomosis around the knee joint. Okay, so it gives on either side, on the lateral side as well as the medial side, along the boundaries of the popliteal fossa. So as I told you, it has got muscular branches, cutaneous branches, and the articular branches. So the articular branches are superomedial, superolateral and middle genicular, infromedial and infrolateral genicular arteries. So 5 branches: superomedial, infromedial, superolateral, infrolateral and middle genicular vessels. So these are the 5 branches of the popliteal artery. The supromedial artery, what happens is seen winding around the medial head of gastrocnemius, and it is anastomosing with the descending genicular branch of femoral artery. Descending genicular branch of femoral artery, the last branch of femoral artery. Okay, and then of course it is going to definitely anastomose even with the infromedial branch of its own artery. Superolateral genicular artery, superolateral genicular artery anastomoses with the descending branch of lateral circumflex artery. Okay, descending branch of lateral circumflex artery. Lateral circumflex branch again from the profunda femoris artery. Infromedial will anastomose with the saphenous artery, which is again a branch from the descending genicular artery. The saphenous artery is accompanying the saphenous nerve. Okay, superomedial, infromedial. Infrolateral anastomoses with the branches from the anterior and posterior tibial, that is the recurrent branches. Okay, so anterior and posterior tibial, recurrent branches of anterior tibial artery. So recurrent branches of anterior tibial artery and also a circumflex fibular branch of posterior tibial artery. Okay. Okay, so these anastomoses around the knee joint, again I will be repeating this in the blood supply of the knee joint. So, you might wonder why there is a rich anastomosis. That is because when you flex your knee, then naturally what happens is there might be a kinking of this popliteal artery, and naturally what happens is there should not be any compromise in the blood supply. So, as I told you, 4 sets of branches, superomedial and superolateral, infromedial and infrolateral. There is also one more branch which is arising, which is called as the middle genicular branch, piercing the oblique popliteal ligament. Anything with the name middle genicular will pierce the oblique popliteal ligament. Just remember that. Okay. Coming to the popliteal vein. So here you are able to see the popliteal vein. It is actually formed by the union of anterior and posterior tibial vein. Okay, it is actually formed by the union of the anterior tibial vein and the posterior tibial vein. Actually, anterior tibial vein and posterior tibial vein are in the form of venae comitants. They are not a single venous trunk. Instead, anterior and posterior tibial are in the form deep veins. They are in the form of venae comitants. They unite at the lower border of the popliteus to form the popliteal vein, and they extend up to the adductor of hiatus magnus, and it is going to continue as the femoral vein. Okay, so that is the formation by the venae comitants of anterior and posterior tibial vein and continuing as the femoral vein. So mainly it receives the short saphenous vein, which is piercing the deep fascia of the roof of the popliteal fossa, and then it is ending in the popliteal vein. So main tributary, one is the two formative tributaries we have seen, anterior and posterior tibial vein, and the next one what you are able to see, the next main tributary is one of the superficial vein, which is the short saphenous vein. Okay, so short saphenous vein mainly drains the lateral side of your foot and also your posterior part of your leg. Okay. So we have finished about the popliteal vessels, mainly the popliteal artery and the popliteal vein. Now we are coming to the nerves. Mainly the first nerve is the tibial nerve, which is a branch of sciatic nerve. Ventral branch of the ventral rami, and the root value is going to be L4, L5, S1, S2 and S3. So of the two branches of sciatic terminal branches, this is the largest branch. It is also called as the medial popliteal nerve. Okay, it is actually called as the medial popliteal nerve. So it is descending vertically downwards, not an oblique course. In the upper part, it is related or present lateral to the popliteal artery, then crosses posterior in the middle, and then what happens? It lies medial to the popliteal artery in the lower part of the popliteal fossa. Okay, and it is overlapped by two heads of the gastrocnemius, and then it enters the posterior compartment of the leg along with the posterior tibial vessels. So, along with the posterior tibial artery and vein, under cover of the tendinous origin of the soleus muscle. Okay. So that is mainly about the tibial Now enters the posterior compartment of leg or posterior crural region along with the posterior tibial vessels. Okay. So that is what I told you, the relationship of these nerve, how it is present first lateral to the artery, then crosses, and then medial to the artery in the lower part. So branches, mainly muscular branches, they supply the two heads of the gastrocnemius, medial head of gastrocnemius, lateral head of gastrocnemius. It also supplies the plantaris, then it supplies the soleus and popliteus muscle. Okay. So muscular branches to gastrocnemius, soleus, plantaris and popliteus muscle. All the branches arise from the lateral side of the nerve, the tibial nerve, except the branch to the medial head of gastrocnemius, which arises from the medial side. Okay. So the medial side of the nerve is considered to be the safe side fairly as compared to the lateral side, because any injury to the lateral side of the nerve, then naturally what happens is the nerve supply to all these muscles will be affected. Okay. So that's what I told you, all from lateral side except to the medial head of gastrocnemius is from the lateral side. Then the nerve to popliteus. When you look at the nerve to popliteus, it actually, what happens is, supplies from the lower border of the popliteus muscle. It winds around the lower border and then supplies the deeper surface, or you can call it as the anterior surface. Okay. It supplies the deeper surface. So it does not supply on the dorsal aspect of the muscle. It passes through the lower border of the muscle and then it supplies from the anterior surface. That is the nerve to popliteus. The nerve to popliteus, apart from that, also supplies your tibialis posterior muscle, superior tibiofibular joint, interosseous membrane, then inferior tibiofibular joint, and also it also gives a nutrient artery to the tibia. It also gives a nutrient artery to the tibia. So that is the branches, mainly the muscular branches, especially the nerve to popliteus. So nerve to popliteus, apart from supplying the popliteus muscle, also supplies the superior tibiofibular joint, tibialis posterior, interosseous membrane, and the inferior tibiofibular joint, and through the nutrient foramen it also supplies to the tibia. Articular branches, mainly it gives superomedial, infiromedial and middle genicular nerves, all the medial side knee joint, superomedial, infiromedial and middle genicular branch. The middle genicular branch again pierces the oblique popliteal ligament along with the middle genicular vessels. So here you are able to see the tibial nerve and all the branches which are given from the lateral side, lateral of gastrocnemius, plantaris, nerve to popliteus, winds around the lower border, and as I told you, it's going to supply the other structure which I have listed. So these are the two heads of the gastrocnemius which have been retracted for you, which is also supplied by the tibial nerve. So only to the medial head of gastrocnemius arises from the medial side. Apart from that, all the other muscles, and that is the soleus muscle for you, again gives a branch to the soleus muscle. Okay. So branch of tibial nerve supplies popliteus and also supplies these structures which I have already mentioned: superior tibiofibular, interosseous, inferior tibiofibular, tibialis posterior, and also to the tibia through the nutrient foramen. The next branch which you come across, the smaller branch of the sciatic nerve, is the common peroneal nerve, also called as the lateral popliteal nerve, L4, L5, S1, S2. Dorsal branch, it is actually the dorsal branch of the ventral rami. So the nerve appears beneath the tendon of long head of biceps. So almost on the lateral wall you are able to see beneath the tendon of long end of biceps slopes downwards and laterally medial margin of the biceps tendon. Then at the lateral angle of the fossa, it is crossing superficial to the plantaris, and there it is very intimately related to the head of the fibula lying on top of a very thin sheet of popliteus. So there the nerve can be rolled against the bone, something like your ulnar nerve which can be rolled against the humerus. Okay, so the nerve can be rolled against the bone, and then it is related to the neck of the fibula. Then deep to peroneus longus, it divides into the deep and superficial peroneal nerve. So the common peroneal nerve is ultimately going to divide into the superficial and the deep peroneal nerve. Very intimately related to the head and then to the neck of the fibula. Okay, after passing deep to the biceps femoris muscle. Okay, so the branches which is going to be given by the common peroneal nerve are cutaneous branches. So mainly it gives the sural communicating nerve which is going to join with the sural nerve, which is again a branch of the tibial nerve. So tibial nerve gives sural nerve. Sural communicating nerve is from the common peroneal nerve, joins with the sural nerve, and then it is going to supply the skin of the posterior part of the calf. Then the other branch is the lateral sural nerve or lateral cutaneous nerve of the calf. It is called as the lateral cutaneous nerve of the calf. Skin of the upper lateral part, skin of the upper lateral side of the leg, lateral cutaneous nerve of the calf. Cutaneous branch, sural communicating and lateral cutaneous nerve of the calf. Articular branches again to the knee joint, superior and inferior or superolateral or infralateral genicular nerves and recurrent genicular nerves. Okay, so the recurrent genicular nerve arises where actually the nerve divides into superficial and deep peroneal nerve. Okay, so superolateral and infralateral genicular nerves and recurrent genicular nerves from the common peroneal nerve. Superomedial and infromedial and middle genicular nerves from the tibial nerve, articular branches. Apart from the tibial nerve, also gives vasomotor branches, sympathetic nerves to the blood vessels, mainly from the T10 to L2 segments. So the sympathetic flow arises from the T10 to L2 segments of the spinal cord, vasomotor branches, and then what happens is they supply to the blood vessels. So that is mainly from the tibial nerve. Okay. The next content what you are able to see here is the popliteal lymph nodes. So what you are able to see is the popliteal lymph nodes. They are actually present in 3 sets. So or you can tell at least in 3 places they are seen. One is where the short saphenous nerve, short saphenous vein is going to terminate into the popliteal vein. The place where the small or short saphenous vein terminates into the popliteal vein. There you can see lymph nodes. So they mainly drain the either sides of the back of the leg, okay, and from the lateral margin of the foot and the little toe. Lateral margin of little toe, lateral margin of foot. So that is along the venous drainage of the small saphenous vein. What are all the areas drained? These lymph nodes drain those lymphatics. Then the few lymph nodes are actually present between the artery and the knee joint, and they actually drain the lymphatics from the genicular vessels, knee region. Okay, they are present between the knee joint and the popliteal artery. The next rest of the nodes are situated on either side of the popliteal vessels, and they drain along the anterior and posterior tibial vessels. Okay, so 3 groups: the junction of small saphenous vein draining the lateral side of the little toe, leg, and the posterior part of the calf, and second one in the knee region drains along the genicular vessels, and along the popliteal vessels they drain from the efferent lymph vessels from the tibial lymph. And then ultimately all these, what happens is the efferents drain into femoral vein. Along the femoral vein they go to the deep inguinal nodes. So along the femoral vein they go to the deep inguinal nodes. So that is about the popliteal lymph node. So there is nothing much to describe about the fat. So we have finished about the vessels, then we have finished about the nerves, and then we have discussed about the popliteal lymph nodes. Coming to the applied anatomy, so common peroneal nerve injury. Okay, so injury to the common peroneal nerve when there is a fracture of the neck of fibula. Any pressure, undue pressure or trauma, what happens is fracture of the neck of fibula. Then common peroneal nerve is injured, then it leads to foot drop. Okay, so your foot is actually, what happens is plantar flexed, because all the muscles of the extensor compartment of your leg, the front of leg region and the lateral leg region, extensor muscles and then their peroneal muscles, what happens is are all paralyzed. So naturally what happens is your foot is actually plantar flexed. So plantar flexed, no eversion, it is adducted and inverted, but dorsiflexion of lateral four toes, dorsiflexion of the foot or ankle is not possible, but the lateral four toes alone is possible. It is because of the lumbricals and interossei whose nerve supply is intact. That is, if the tibial nerve is intact, no injury to the tibial nerve, then naturally dorsiflexion of the lateral four toes is retained. Okay, so here you are able to see the extensors bring about the dorsiflexion, but in case of foot drop there is no dorsiflexion, there is plantar flexion, but lateral four toes alone can be dorsiflexed. Now injury to tibial nerve, naturally it will paralyze your gastrocnemius and soleus. So absolutely you won't have plantar flexion. So naturally there will be dorsiflexion of the foot because of unopposed action of the extensor muscles. These muscles are paralyzed, gastrocnemius and soleus, so there cannot be any plantar flexion. Popliteus, tibialis posterior, all those muscles. Your flexor group of muscles of the back of the leg, all there is motor paralysis, so it is dorsiflexed and it is everted because again unopposed action of the everters of the foot, peroneal muscles, peroneus longus and brevis. Okay. Then what happens is, due to the intrinsic muscles of the sole of the foot is also paralyzed, short muscles, then what happens is the person cannot stand on the toes. Okay, so you cannot raise your heel and then stand on your toes because your lumbricals, interossei, everything are paralyzed if the tibial nerve is paralyzed, because tibial nerve only is going to divide into medial and lateral plantar nerve and it is going to supply the muscles of the sole of the foot. Not only that, these muscles at the behind, they flexor digitorum longus, flexor hallucis longus, they are also going to enter the sole of the foot. So naturally the muscles, intrinsic muscles of the foot, there is a paralysis. Okay, so dorsiflexed foot is everted, sensory loss on the sole of the foot. Again, complete sole of the foot, there is sensory loss. So what is Baker's cyst? So inflammation of a bursa which is present between your tendon, semimembranosus bursa, and naturally what happens is it occurs in conjunction with arthritis. So any arthritic conditions will also inflame this bursa, semimembranosus bursa, which will be swollen, and you can call it as Baker's cyst. So when there is a rupture of this cyst, naturally what happens is it might mimic deep vein thrombosis. So if the deep veins, popliteal region, popliteal vein, if there is any thrombosis, then naturally symptoms of thrombosis will be pain and tenderness over that region. So here also it might mimic in the same way pain and tenderness over that region. The skin might become red or bluish in nature, and you might feel the skin a bit hot. So all these are the symptoms of deep vein thrombosis. Here in case of if the cyst, Baker cyst ruptures, it might also mimic those symptoms. The next you are able to see aneurysms, abnormal dilatation of the artery you are able to see, but here the vein only is shown as dilated. This is venous aneurysm. This is PPVS, proximal popliteal vein aneurysm. You are able to see an abnormal dilatation. This is lower part of the vein, distal popliteal vein aneurysm. Deep to the vein only, this you are able to see the popliteal artery, but here venous aneurysm. So any abnormal dilatation of the vessel is actually called as popliteal aneurysm. So pulsations you can feel in the popliteal fossa of the vessels. Now, but even though there is a dilatation, what is present immediately above it is the deep fascia, which is a thick fascia. It is unyielding fascia. So naturally it is not allowing this dilatation to further expand, and naturally it might compress your tibial nerve. Okay. So nerve compression might take place. If this is compressed, then naturally plantar flexion is lost. Again, the reason I told you in the previous slide itself, paresthesia, abnormal pricking or tingling sensation of the foot and posterolateral aspect of the leg. Okay, paresthesia occurs foot and posterolateral part of the leg. So that is about the popliteal aneurysm. So today we have completed the popliteal fossa and the contents, boundaries and the applied anatomy. So thank you very much for your patient listening, and we will meet again with one more topic on lower limb.